You know, in medicine, every patient is kind of like a puzzle. You got a collection of symptoms, maybe a strange lab result, or a little detail that's buried deep in their personal history. So what's the doctor's job? Well, they've got to be a detective, piecing together all those clues to solve the mystery of what's really going on. And today, we're opening the case files.
And that's really the theme for what we're doing here. We're going to crack open the files on 8 really fascinating medical mysteries and see exactly how doctors follow the evidence, connect the dots, and ultimately solve the case. So here's how we're going to break down our investigation. First, we'll start by looking for mysteries hidden in the blood. Then, we'll move on to cases that show up with really sudden alarming signs. And finally, we'll uncover some secrets that are buried in a patient's long-term history. Let's get started. All right, let's open our first set of case files. These take us right into the world of hematology, where, a lot of the time, the answers are literally circulating right there in the patient's veins. Okay, detective, here are the clues for our first case. We've got a patient who's getting nosebleeds and bruising easily, but, and this is the interesting part, their platelet count is totally normal. Their prothrombin time, or PT, is also normal. The only red flag is that their APTT is prolonged. So, what's the story here? What are these clues telling us? And the diagnosis is von Willebrand disease. If you got that one, nice job. Here's the really cool part. Von Willebrand factor actually has 2 jobs. It's like the glue that helps platelets stick together, but it also acts like a bodyguard for another clotting factor, factor 8. So when it's not working right, you get this double whammy. The platelets don't stick well, and you lose that protection for factor 8. That's exactly why the APTT is prolonged. So this is your big takeaway, your clinical pearl. This triad of clues, that surface level bleeding, the normal platelet count, and that prolonged APTT. That is the classic signature for von Willebrand disease. It's a perfect example of pattern recognition in action. Let's jump to our next case, a super high-stakes situation in the ER. A patient comes in with severe trauma, and they are bleeding a lot. The team is already getting packed red blood cells ready to go. But here's the thing. In a massive bleed like this, just replacing the red blood cells isn't going to cut it. What else is absolutely critical to stop the bleeding?
The answer, it's all about a specific ratio, 1 to 1 to 1. This number, it represents a life-saving protocol in the world of trauma care.
So what does that mean? Well, this protocol calls for what we call a balanced resuscitation. For every 1 unit of packed red blood cells, the patient also gets 1 unit of fresh frozen plasma and 1 unit of platelets. Why? Well, think about it. If you just pour in red blood cells, you're actually watering down all the clotting factors and platelets the body desperately needs to form a clot. You can actually make the bleeding worse. The 1 to 1 to 1 ratio replaces everything the patient is losing.
Okay, case number 3. Picture this. A patient is 5 days out from a big surgery, which we know is a major risk factor for blood clots. All of a sudden, they can't breathe, they look pale, their heart is racing. A pulmonary embolism, a clot in the lungs, is at the very top of the list of suspects. With suspicion this high, what's the one test you need to order, like right now, to confirm it?
The answer is a CT pulmonary angiography, or a CTPA. That is the gold standard here. Now, you might be thinking about a D-dimer blood test, but in this case, it's pretty much useless. The surgery itself will cause it to be high. When you have a really strong suspicion for a PE, you don't waste time. You go straight for the test that can actually see the clot. All right, let's move on to our next batch of case files. These next few mysteries, they're all defined by their sudden, really dramatic, and often pretty alarming presentations.
Okay, case number 4 involves an older patient with a very specific problem. This sudden, completely overwhelming urge to urinate, which is then followed by leakage. And there's no pain, just this powerful, unstoppable urge. So what specific type of incontinence are we looking at here?
And yep, this is classic urge incontinence. Let's quickly break down the different types so it's super clear. Stress incontinence is when you leak because of physical pressure, like from a cough or a sneeze. Overflow is what happens when the bladder can't empty properly. But urge incontinence, our patient's problem, that's caused by an overactive bladder muscle, the detruser, that's just contracting when it shouldn't be.
Next up, we've got a kid with really bad eye pain. But the real clues here, they're all in the environment. The pain started hours after playing in the snow at a high altitude. And when the doctor looks at their eyes, they see this very specific finding, diffuse little pinpoint stains all over the cornea. So what in the world connects snow, high altitude, and this delayed, super painful eye injury?
The diagnosis is Photokeratitis, which is basically a sunburn on your cornea. Ouch. And it all makes perfect sense, right? The snow acts like a giant mirror, reflecting all that UV light right back into the eyes. And at high altitudes, that UV exposure is even more intense. It's the damage to the cornea's surface that causes that severe, delayed pain.
All right, next we're looking at a pretty serious heart infection called infective endocarditis. Now, there are a lot of classic signs you might read about in a textbook, little spots on the hands or under the fingernails. But my question for you is, what is the single most common clue that a patient actually has this?
And the answer is just a fever. It's that simple. While things like Osler nodes and Janeway lesions are famous textbook signs, the truth is they're actually pretty rare. The most reliable and most common clue of this dangerous infection is a fever that just won't go away. It's a fantastic reminder for any detective. Focus on what's common, not just what's famous. For our final two cases, we're shifting gears a little. The solution here isn't in some sudden event, but it's hidden deep inside the patient's long-term story and their family history. So here's the setup. A young child, just 4 years old, has a really concerning mass in their abdomen and has been losing weight. But the absolute key piece of evidence, the clue that just cracks this whole thing wide open, is in the mother's medical history. She has a genetic condition called FAP. So how does that connect to her child's liver mass? The diagnosis is Hepatoblastoma. This is the most common liver cancer in young kids, and critically, it has a known and very strong association with FAP. The mother's history wasn't just some random background fact, it was the master key that unlocked the whole diagnosis.
All right, our final mystery. A patient comes in with slowly worsening neurological symptoms in their feet. They've got tingling and they feel clumsy. An exam reveals that they've lost sensation for two very specific things, vibration and light touch. Now here's the kicker, the final clue. They've been taking a common heartburn medication, a PPI, for years. What's the connection?
The diagnosis? Vitamin B12 deficiency. And here's the brilliant chain of events. Long-term use of those PPIs reduces stomach acid, and you actually need stomach acid to absorb vitamin B12 from your food. Without enough B12, the protective coating around your nerve starts to break down, especially in the part of the spinal cord that controls, you guessed it, vibration and light touch, which leads to those very specific symptoms. So from a weird lab result to a tiny detail in a family history, every single one of these cases was solved by finding that one crucial clue. It's such a powerful reminder that every detail matters. So as we close these files, it kind of leaves you with one last question, right? What's the most important clue, maybe even an overlooked one, in your own health story?